Well, welcome everyone to our first collaborative care SIG meeting of the year 2024. This will be our first full year as a SIG, so very excited to get started. For those of you who are newer, how we usually do things is we have a speaker come in to kind of give us some information and kind of talk about some topics that are related to collaborative care and integrated care in primary care and in other settings. And then we usually have time to ask questions and discuss and bring things that we have to our panel of experts. Everyone here is an expert in some way in collaborative care or an expert in getting started. And so we have a lot of great knowledge and experience here, and it's been great to pick each other's brains and tell everybody about what's going on. So we have new leadership for this year. If you've been here before, you recognize me. I am the person who's going to continue on, kind of have a little bit of continuity for this year. So I served as a co-chair with Diane Powers last year, and so I will keep going as a co-chair. This will be my last year on the leadership. And then we have two new leaders coming on that were voted in last year, Laura Sidari, who will be my co-chair, and Monica Harrison, who will be our secretary. And so I thought today I'd give them a chance to introduce themselves a little bit and say hi. And then I don't know, Monica, if you wanted to introduce Annie since you guys work together,
Sure,
and then we can get started.
sure. Laura, you want to go first, and then I'll go, and then I'll go introduce Annie.
Sure, sounds great. So I'm Laura Sideri. I am a general psychiatrist by licensure and have additional training and experience in a lot of different models of integrated care to include, but not limited to, collaborative care. I've been in the collaborative care space working since 2021, and prior to that, received training during my previous time that I spent at Cornell University. I run a blended PCBH and CoCM program in central New York for a community healthcare system. We have 5 different sites right now, and we'll have 7 in the new year. This has been like a really awesome space for me to learn and grow as a psychiatric consultant, both contributing as well as, learning. It's been wonderful to get to dialogue online and offline with people, and I'm really passionate about being in this role and really excited to see where I can help grow the great work that's already been done by Tisha, Diane, and Lori before them. So thanks so much.
I just jump on there with you as well, wanting to contribute to the great work that's already been done by those who have been our leaders at the start of this and created it into the actual SIG. My name is Monica Harrison. I am a licensed clinical social worker by trade, but I am a lover of all things integrated care. I've been doing integrated care for quite some time, kind of fell into it, but that's a story for another day, and have done multiple models, best practices, you kind of name it. Was previously a behavioral health director for FQHC, as well as a large hospital system implementing PCBH as well as collaborative care. I am now with the AIM Center as one of their clinical trainers and practice coach. So I do consulting work now through the AIM Center. And that is me. So I will jump right into introducing our speaker for today. So today we are going to have a speaker who is from the AIM Center, Annie McGuire, who I will let her tell you about herself and her expertise, but she is also a clinical trainer and practice coach at the AIM Center, who's going to be talking to us today about metrics. Annie?
Yeah, thank you, everyone. My name is Annie, and exact same role as Monica. So at any point today, Monica, please pipe in if there's anything I miss or if you have any wisdom to add. And then, but my experience and background, I'm a licensed mental health counselor, also have my master's in healthcare administration, and have worked in the collaborative care realm for the last 15 years. So about 11 years providing direct patient care as a behavioral health care manager. Then my last role was with a larger healthcare organization in Southwest Washington, where I was the director of behavioral health integration and implemented across 10 primary care clinics in that region. So our topic today, I definitely have some experience with developing metrics for programs and tracking metrics and the nuances and difficulty that come with that. So, and yeah, I've been with the AIM Center on and off for about 10 years, but full-time for the last 3 years, almost 3 years. So yeah, that's me. Is it possible for me to just share my screen? We're going through our...
You should be able to. Let me know if you
Okay.
can't, and I will
All
do
right.
something.
We can dive in to our topic of metrics, which some people get really excited about, others not as much. I'll give Diane credit for this catchy title because that's all her. But yeah, we're going to talk about metrics today. We've learned that articulating quality metrics and using these metrics for regular program monitoring and adjustment is a really key factor to a successful and sustainable collaborative care program. So before we dive into those metrics, I just wanted to do a quick review of the key principles of collaborative care, because we're going to be discussing metrics today that are specific to each of these key principles. So these are the principles that are necessary to drive effective collaborative care. And so the first principle is patient-centered team. So the patient, the primary care provider, the behavioral health care manager, all collaborate to effectively using the shared care plans or whatever type of treatment plan that everyone has access to in your EHR. And those should then incorporate patient goals. So everyone should be on the same page about what that patient, about that specific patient's goal. The second is population-based care. So a registry is used to facilitate engagement and outcome tracking in a defined group of patients at the caseload and at the clinic level. Measurement-based treatment to target is where progress is measured regularly and treatments are proactively changed until that clinical goal is achieved. Evidence-based treatments that's providers using treatments that have been research evidence for their effectiveness, and this includes medication treatment, but also the brief behavioral interventions that are provided by the behavioral health care manager. So all aspects of treatment should have some evidence for effectiveness. And then accountable care, the first four principles really lay the foundation for this fifth principle. And this just means that the care team is accountable to the outcomes and the quality of care and the clinical outcomes, not just the volume of patients they're seeing. And so just really taking ownership of the quality of care. All right, so we can dive into talking about the principles and the kind of corresponding metrics. So this first principle here is population-based care. And then if you, on the right-hand column for each of these slides, the suggested target for the metrics are shown. So, and these are just targets that we've developed over many years of implementing this model. And yeah, so may have some variability based on organizations and patient population demographics and things like that. But in general, these are kind of this is kind of what we see with a successful collaborative care program. So as part of developing a collaborative care program vision, healthcare organizations identify their focus population. So one of the things they may want to measure is how well they're reaching that specific population with screening. So they can identify who needs care and get them enrolled in collaborative care. And for health equity purposes, it's a good idea to look at this and the other data we'll talk about by race, ethnicity, language, age, and other health equity markers. And although it's called out for a couple of the metrics, it's really an overarching analysis that should be part of metrics monitoring. The second thing healthcare organizations may want to measure is access. So how long it takes between a positive screen and that initial assessment. Similarly, an access measure could be measuring the time from that initial assessment to that first follow-up visit. And we know from published literature that patients are more likely to improve when their first follow-up visit is within the first 30 days, within 30 days of that initial assessment, and ideally sooner. Next, it's a good idea to track the proportion of eligible patients who enroll in collaborative care. There's a number of studies that report on this for programs that serve diverse patient populations. The average that is reported is about 50%, though cost share issues can drive this up or down. Another factor that can influence enrollment and engagement is how the patients are identified. So programs that do case finding through electronic means, more of like a population health approach, rather than screening and referral from a primary care provider, typically have lower enrollment rates. I'm guessing that, we know that the primary care provider plays a really important role in engaging patients. And it doesn't necessarily always make sense to me why those rates are lower, but that's kind of where the data lies. And I can tell you that I did an implementation with one clinic where we identified patients via a list in the EHR, and we were looking at medical diagnoses that have high rates of comorbidity with depression and anxiety, and we identified patients with COPD, CHF, and diabetes with A1C at 9 or above, and who had been hospitalized in the last 30 days, and we couldn't fill our caseloads, which blew my mind, but we had to then expand the criteria and open it up to more of that universal screening. But I also think one of the downsides of identifying solely by a specific population is that then the goal of collaborative care, or one of the goals, is to identify those patients you never would have. So it's really, the people that are just screened annually, who then we identify that these things that they're experiencing happen to be depression symptoms, and maybe they didn't know that, or maybe they weren't presenting or articulating those concerns. So just the ability to identify patients that we would have never identified, and get them some treatment is kind of one of the beauties of it. So I think, just thinking about how you want to identify those patients.
Annie, springboarding off of that, so there's a question in the chat. Could you share more about how you establish the target population, assuming it's not universal?
Yeah, I mean, there's a variety of ways you can do that. I totally understand hesitancy to just open universal from the get-go, especially with a new launch of a new program. That can be daunting. So definitely perfectly fine to start with more of a focused group and then expand if as needed. If your caseloads aren't filling, then expanding criteria. But you could take all sorts of directions. Different implementations I've worked in, we did postpartum patients and screened those patients for collaborative care. I'm trying to think, diabetes visits, we screened those patients. We had also done just reports of patients that had a diagnosis of depression or anxiety on their problem list. You can do reports of the last PHQ-9 score, and then outreach to those patients to get a more up-to-date one and see if there's still a need there. So you can pull by, all the PHQ-9 scores above 10 in the last 3 months, and then contact those patients and get a more recent screen. That's a good way to do it. Any other thoughts on how to hone in on a population?
I think that's where that collaboration with your upper leadership, the clinical leadership that you're partnering with, it can be really helpful for buy-in also with using that strategic target population to create and fill the needs of your patients as well as your healthcare system. And I think that point that you made about also thinking about inadequate caseload, like even with a population you might expect to be very full, that ability to pivot is super important, because also sometimes people can be like, well, I thought we're only taking patients with COPD, that piece
Yeah.
of being able to have that communication about the target population, both to expand as well as sort of focus your target group, is important.
Yeah, thanks. I think that's a really great point, because sometimes we can get stuck and really need to probably expand sooner. Another thought would be, if you are ultimately wanting universal screening, but that feels really daunting in the beginning, definitely starting with, 1 or 2 PCPs. That's another great approach. You're not going to, 20 PCPs. There is this risk of kind of bombarding your behavioral health care manager, but just also another great way to kind of test workflows and iron out kinks. And also then you have a primary care provider champion to, provide that testimony of this helped my patients, and I've been working in this team-based model, and these are the results and outcomes that I'm seeing. So having that can also really help buy-in. So just another kind of approach for if you're wanting to do universal. Cool. So so caseload reach, we want to look at caseload reach, and then there should be both a front door and a back door to collaborative care. So patients should not be kept on the caseload indefinitely, which is why there is the relapse prevention planning, and why that is so important, and why a good registry can help you identify patients who may be ready for relapse prevention. It can be hard for a behavioral health care manager to let go of patients that they really like working with, if they've made a good connection with that patient. But there are other patients who also need help, and staffing resources are not infinite. So I think when you're training behavioral health care managers, that's really important to drive home, because that can be a big transition, and a difficult transition, and kind of a learning curve. But they're definitely, you're not able to hold on to those patients that make you feel great, because it feels like you're actually doing a good job, because they're getting better. Even though you can't hold on to those patients, there are other, points of job satisfaction but it's a little bit different. It's over time, you're going to have be able to look back historically and see, like, wow, in the last year I saw 135 patients, and 68% of them reached response or remission. And that's a different type of job satisfaction, but can help kind of justify that kind of ongoing, when someone's getting better, someone else they are moved off of your caseload and someone else comes on. So, but definitely just knowing it can be a hard transition depending on kind of the background of folks. Finally, looking at frequency of contact can also be really helpful. The behavioral health care manager should strive to have at least 1 contact per month with their patients at a bare minimum, and more frequently if you have availability, and when symptoms are more acute. So earlier in treatment, and then at any point during treatment when symptoms are more acute. Most organizations, I would say, strive for 2 contacts per month until the patient has a relapse prevention plan in place. Then the frequency can reduce to, once a month or every 6 weeks until that episode of care ends. And the next metric is measurement-based care. So measuring the proportion of contacts that include a symptom measure can get left behind when developing a metrics dashboard. So it's easy to assume that these are being done regularly, but sometimes we do see a gap between expectations and actuality. And I can tell you that overseeing a large group of behavioral health care managers, this happened a lot. So really important to keep your eye on all sorts of factors, turnover in the front desk staff, so they're not handing out the screen, and then there isn't time to do it during the visit. Patient is refusing to do it. It upsets the patient, and they don't understand why. All sorts of factors of why it's not happening. So definitely keeping tabs on that is really important. Some patients, they really don't understand why they would need to fill out these same measures repeatedly. It doesn't make sense. They understand the screening side and the initial, but many, need some psychoeducation around that measurement-based treatment to target. And if you take the time, if the behavioral health care manager can take some time and explain to the patient, so they can understand that these symptom measures are equivalent to having your blood pressure taken. If you are treated for hypertension, and that they can get better faster when the team knows when the treatment should be adjusted as quickly as possible. We can be more proactive, and they're usually willing to participate then. Just kind of explain it. We want to know what's working of the things that we're trying, so we can really shift course at any point if we need to. So also communicate. Yeah.
We should have asked you, I'm sorry. If there are questions, do you want us to ask you at the end or in the midst of what you're talking about, if the question is about that?
In the midst is totally fine. But I cannot track the chat.
No, we got the chat for you. We got the chat.
Thank you. That is like a skill that...
Monica, you want to take that question away?
Yeah, so there was a question about, could you comment on how you coach the PCPs to describe the target population? They say, I will get some pushback from PCPs with comments like, I need to help with all my behavioral health patients. What do I do with folks too complex for collaborative care? We have very little community mental health resources. So they're just wondering how to coach the PCP into describing what their target population is.
Like how to get buy-in from the PCP that there's a target population versus all of the patients that they have that actually need care. Yeah. That's a tough one. Honestly, that's a really tough one because primary care is de facto mental health treatment, and they see it multiple times a day, every single day. I guess my approach historically was to just explain to PCPs that with this model, we're going to be able to see, probably having a percentage of your patient population that you want to be able to provide services to, and ideally comparing it to a previous state. So either 0 if you had no collaborative care, or one of the organizations I worked with, we had, they were doing more co-located traditional psychotherapy and had patients on their caseload for, years at a time. And the reach was about 1% of the patient population. But by implementing collaborative care, we were able to get that up to, 19, 20%, which, so that's a big deal. But we also want to help the people that we can effectively help, where there's evidence that we can help improve their symptoms and get them to response or remission state. And that isn't necessarily the case for patients that are more severe. They're not going to benefit as much. And then that's time taken away from these patients that could really benefit. So it's kind of a long explanation, but yeah, we want to help this is the way we can help the most people. But never, can we help probably everyone?
Yeah, no, that's great, Annie. Thanks. I love that explanation. And I think I heard you coach us once with saying you can even do like a dose of collaborative care, kind of helping the PCP with diagnostic clarification. That I think is a really important point to hone on when you're trying to build that PCP buy-in of like, maybe this isn't forever care, but maybe this is a chance to get your care manager and your psych consultant in the mix, helping the PCP like, all right, this is, long-term, we got to get them in, specialty psychiatry, but right now, because they're in your office, here's how we can help support you with at least moving the needle in a way that's, safe and evidence-based. So I hope that your question.
Definitely. Yeah. It can be so stressful for PCPs if they have someone with more acute mental health needs and they can't be seen in specialty for 3 or 4 months. That's really stressful. What are you going to do? I remember a patient moving from out of state and needed refills on, had a diagnosis of schizophrenia, needed refills. And so being able for a PCP to quickly talk to the psych consultant, but and this is program, you can decide for your program if you want to have any sort of bridge work, but there definitely are programs where they decide that that's going to be a service that they provide in getting that patient actually through the door at the specialty provider, because the statistics on that are really dismal. So, having that getting started on, antipsychotics or the medication that they need, but probably not addressing it fully until, maybe it's just focusing in on the depression, anxiety symptoms, and waiting to address the concerns about ADHD until they get to the face-to-face with the psychiatrist. It doesn't have to be everything, but if it can be a start, and reduce someone's PHQ from 27 to 21, that, that's progress. And that's also what, there's never an expectation that 100% of your patients reach response or remission, because there are going to be some that, whether it's known from the beginning or we figure it out partway through, that they need more care. And that can be a role of your behavioral health care manager if you decide to have that as an aspect of your program. Other programs don't have the capacity, and that is not an appropriate referral, and they set a boundary there, and both are okay. It's kind of what you want to do, what your kind of community resources are, what the capacity of those are, all sorts of factors. But yeah, it's stressful for PCPs, I guarantee, because they see a lot, and definitely quite a bit that's not appropriate for managing long-term in primary care. All right, any other questions in the chat box? Are you good?
No, just lots of good conversation.
Okay. That's where I get lost, and then I can't anyway, so I appreciate your help, Monica. Let's move on, but basically, yeah, you can't do treatment to target if you don't have measures, or if the measures are out of date. So very, very critical. So definitely check in on if those measures are happening. All right, this one's a little more dense. So treatment to target, which builds on measurement-based care principle that we just discussed. So quickly identifying when treatment needs to be adjusted is one of the cornerstones of collaborative care. Metrics are essential to helping the treatment team accomplish this. So one of the most important components of any CoCM program is that systematic caseload review. And so these meetings should ideally happen weekly, even in the beginning when the program is just getting started. When things are slower at the beginning, is when that psychiatric consultant and your BHCM can really hone in and develop their working relationship. The behavioral health care manager will learn what information that psychiatric consultant needs to feel comfortable making their recommendations, and being consistent instead of ad hoc is absolutely essential to this model. So initially, there will be plenty of time to talk about all the patients because the caseload is low. And I always recommend that teams talk about all new patients when caseloads are low. So you also don't want to get used to talking about one patient over the course of an hour and having that much time, but starting to practice talking about more than one patient in an hour, because ideally you need to take that time to get your rhythm down in those early days, so that as that caseload grows, you can talk about 6, 8, 10 patients per hour. So definitely requires that your behavioral health care manager is really prepared with a succinct summary of the information that the psychiatric consultant needs to make meaningful recommendations to the PCP. So, definitely some strategies for doing that is when building kind of your initial, if it's new patients, when building initial assessments and documentation templates, really incorporating all of that information that your psych consultant needs, and consulting with them on the development of that document. So you're making sure you're getting the information, ideally the first time around, but it doesn't always happen. They may have questions and you need to go back to the patient. That's part of their job, is to ask you questions. So, but there are definitely strategies to try and get the most information you can early on. So as the caseload grows, it's important to be efficient and to have a registry that helps you quickly identify the highest priority patients for case review. And so to accomplish this, your registry should keep track of the length of time since the last case review and whether the patient is at least 50% improved since baseline. And when the caseload is full, it's tough to quickly prioritize patients without some sort of tool to help with these calculations. So some sort of tool that can say this patient hasn't been seen in the last 60 days and also, or hasn't been consulted on in the last 60 days and also hasn't improved by this amount from baseline. And then lastly, the most important metric is patient clinical outcomes. So you want to know what proportion of patients engaged in treatment have experienced response or remission, and whether this is as expected or not. So it can be helpful to track keep track of this not only for your current active caseload, but also historical data, so you can watch your program growth over time and effectiveness of your program as you become more seasoned and as your program evolves, to see what those trends look like, and just observe if they're getting higher and lower and what information that provides. Patient-centered care is our next principle. And so this is patient experience is one of the elements of the quintuple aim, which we all know. So increased satisfaction with care has been shown with collaborative care. As I mentioned earlier, patients receiving collaborative care were significantly more satisfied with their depression care. And it makes sense because there are, great rates of clinical outcomes. So it makes sense that that would also impact the patient satisfaction, but also just how quickly they're able to kind of communicate with someone on their team and have making sure how everyone's on the same page and really aligned with their individual goals is a huge factor.
Annie, could you speak more to how frequently you recommend the satisfaction surveys? A lot of clinics have this set up to go out after every appointment. And so it can be sometimes difficult with the check-in format to catch these patients. Do you have any more guidance you can provide about that?
Yeah, I mean, every appointment sounds hard to do to me, just because we're also, I think, the most critical, not the most critical. We want to make sure there's patient satisfaction as well, but we're also, you don't want them to be over surveyed. We're also asking them to complete the PHQ-9 at each visit, and that's really critical. So being strategic about it, but yeah, I mean, I've definitely worked with organizations that do it quarterly, that do it at the beginning of an episode of treatment and at the end of an episode of treatment. I think looking more episodically can help you get information, probably from more patients and more accurate data. But yeah, you could do more of a time approach with quarterly, but I would say episodic mostly. Monica, did you have any other approaches that you use as far as timeframes for assessing patient satisfaction?
No, I do think there's so much variation. We did ours episodically just because there are all of these nuances in between that happen. I mean, I'm sure for some of you, it's no surprise that in the beginning, it can be very challenging for patients. And so the responses that you get on a survey from the beginning with the patient versus what you get at the end, once things have improved, or even if they haven't improved, but you got them connected to specialty or what have you, it's just very different. So we took that into consideration and decided to do, we did the first month and then we did the end of the episode of care.
Okay. Thank you.
Someone else, oh, I was saying someone else, she could have came off a mute and talked, but anyway, I'll repeat what she said. So Verna says, we do after first contact, after third contact, and at the end of care. Verna, any thoughts on like just the justification or what you've seen for what's been helpful versus what's not?
Yeah, I think the reason we started to do after the first contact is because we noticed, and this was really a training issue, that we were losing some people after the first contact. So we wanted to get kind of some direct feedback. And we found out it was directly related in a lot of cases to two things. One is not really having the care managers have a really good understanding of how to incorporate the tools into conversation. And so the patients were like, well, all I'm going to be doing is filling that out, and I don't want to do that. Like, what's the point of that? And so that actually directly sort of carried over. And we found after the third contact that that was where we might lose people to disengagement. So we were very interested in some direct feedback. And then, of course, at the end of care. But interestingly enough, after the first has dramatically changed with some training. But that's why we initially did it. It was really helpful because we got some really good feedback.
Yeah, I can imagine that would be helpful.
Yeah, and I also think disengaged patients, like, part of the problem with patient satisfaction surveys for me is, you're asking the people that are coming to care, that are engaged in care. What I want to know is like, who did we lose? And so, one of the things that I will occasionally do is have someone reach out to the people and say, hey, we just want to ask you some questions, and have gotten some really good feedback, re-engaged some people, but also gotten some good feedback.
Mm-hmm. Yeah, I can imagine that would be, maybe the expectations weren't the same as kind of how it was pitched when they were first referred, or wasn't kind of what expecting to enter. So that could
what's
be really
interesting is we found that care managers who felt like they had to go into this really detailed description of like what is collaborative care, which was totally not engaging to patients, like big surprise there. And so like we actually it was, so that's like, those were some of the training things that we uncovered.
Yeah.
Verna, Tina asked in the chat, what are the questions you're asking in the survey?
So, we've actually transitioned a little bit, and, one of the things that everybody cares about now a lot is the Net Promoter Score. So how likely are you to, refer a family or friend to, Concert Health or to whatever. And so that's like one of the primary questions.
We did have a question in ours, Tina, that was specific to the behavioral health care manager, because we didn't have I know in some systems and some organizations I work with, the behavioral health care manager is the one giving the survey. We went against that because there's just sometimes some real information that you need that you can't get if it's the person that they want to talk about that's asking the questions. So we actually had some questions that revolved around that interaction between the patient and the behavioral health care manager and the helpfulness of that. I think I think it's important, and I don't want to go too far off on a tangent, but when we start talking about health equity and including patients' voices and things, we really need to be making data-driven decisions that aren't only about like these outcomes data, but also the information that you receive from a patient, even if it's qualitative, is data as well. And making some decisions and adjustments based on that is a big component of health equity. And I think sometimes it goes by the wayside, or we just think we could just do a satisfaction survey and that's it. We don't try any other avenues to get the patient's voice in the mix of services that we're providing or changes we're trying to make. And I think it's just important to think about other ways as well for your patient who maybe can't read and don't want to fill out a survey, but just to start to think a little bit outside of the box, to get that patient voice also as a part of your data and then driving the decisions that you're making.
Yeah, excellent points. Thank you, Monica. All right. So fourth principle is evidence-based treatments. I would say this is probably the most challenging metric to track, but it could be important, especially if behavioral healthcare managers are more accustomed to providing longer term, open-ended, or more talk therapy. Even though they've been trained in evidence-based techniques, it can sometimes be easy to engage in kind of just general supportive counseling rather than proven techniques. But definitely challenging to track because the mode of treatment may be embedded within a progress note in the EHR. But if you are able to figure out a way to track it, it could be helpful. I've seen organizations who have built their own registries incorporate, having a drop-down menu that has the list of different evidence-based behavioral interventions and having the clinicians select which ones were utilized during that episode of treatment. Something like that could be one way to measure. But yeah, it can be a difficult one. Does anyone have any ideas for measuring what specific behavioral interventions? I think we can more easily measure, whether we're prescribing psychotropic meds in with an evidence-based approach. That could definitely be easier, but as far as behavioral interventions, it can be more difficult and might be more kind of conversational with whoever's supervising the group of behavioral health care managers, or periodic reviews of chart notes. But Okay. And lastly, accountable care is that fifth principle. Accountability is not all about the money. So from a healthcare organization's perspective, it's how well do processes and outcome metrics align with their vision, their goals, and their expectations. So linking back to that, the vision activity at the very beginning of implementation, and really clearly identifying goals and expectations from the beginning. And yeah, as a payer, are you achieving expected cost savings? When the payers take a look at these programs within different organizations. Any other questions? Ooh, that's all I had for you guys today.
No questions in the chat box.
All right, we had some great questions throughout, so that worked out well. Laura said to help track on evidence-based psychotherapeutic strategies, we have in the care plan, our BHCMs list 1 long-term measurement-based goal, 2 interventions used, and 3 SMART goal homework. Yeah, it'd be helpful to have that drop-down feature to then track and give a list of common targets, interventions. And then these goals go into the relapse prevention plan section once met. I like that. And David Haddock, how does a patient's opinion that the need for this care figure into your outcomes? Like the need for whether there's kind of patient buy-in to participating in collaborative care, is that what you're asking about?
David, are you able to come off mute? Because I was wondering if he was saying the patient's opinion that they
Sure,
no
I'm
longer
sorry,
want care, but I wasn't sure.
made a
Not
typo,
sure.
I didn't correct it. I'm just wondering if the patient decides that they no longer need to be in the program, how do you record that as part of your outcome metrics?
Yeah, and that definitely happens for sure. I can recall that with several patients, where they didn't necessarily get to where we would want them to be, but it's not us receiving the treatment. It's the patient. So, I've definitely had patients that feel like they've made some progress and they have some tools and their life has picked up and it's busy and they're going to, move forward from here and come back if needed, and then still perfectly okay to jump in and do that relapse prevention plan, even if they haven't necessarily reached a specific target. Or some patients just start and they say, this approach isn't for me. I really am looking for something different. And that's okay too. But yeah, also why those goals are never 100% of your patient is going to complete. There's kind of 3 ends to collaborative care. Either you get better and you have a relapse prevention plan, or you maybe they fall away from care, you're unable to contact them. Yeah, what would the third one be? And others.
What did Timothy Leary say?
Referral to specialty. Yeah, referral to specialty if they're not getting better. So I'm sorry, what were you saying?
Well, anyway, since that's not a metric-based outcome, how do you roll that into the overall evaluation of the program and your value-based payment models?
I think that goes to what Monica had shared about taking qualitative data and using that for quantitative data purposes. I can say for in our equity, inclusion, diversity programming, we found that surveys were not really helpful for reaching those populations. So having focus groups and then taking that data with a third party and turn that into quantitative data was really helpful. So looking for ways to turn that sort of qualitative piece into like a yes, no, or, here's the different outcomes, turning that into a metric can be helpful. Because the measurement-based approach is the most important evidence-based component of collaborative care. It's important to measure that in some way. So looking for those qualitative conversions into quantitative is super important.
I just
I
want
think
to
it's-
highlight the difficulty of determining outcomes for behavioral health, because it, we try to force it into a medical model where you have a quantitative number that says yes or no. It's not that easy, as you're pointing out.
Yep.
So sometimes we just go down this path of trying to follow the medical model, and it's forcing us to fit into something that's not natural.
Mhm. Yeah, I totally
As
agree.
someone who,
Go ahead.
yeah, I'm just saying, as someone who goes to way too many quality meetings in the medical world, also it's difficult for everyone, right? Like you have blood pressure measures, that's awesome, but we all know that actual what's healthy blood pressure, what's expected blood pressure is different by age and different by depending on medications people are taking, and there's so many variables. And so anytime we're trying to create a metric and say this is the percent of the population that should have this number, it's a pretty complex situation.
Mhm. Yeah.
I know our group, our geriatric primary care providers are always reminding us that the regular blood pressure metrics are not mostly attainable with their population. And if you think about people who are pregnant or people who have all sorts of different situations, and I think the more ways that we can parse out our data, the better. So we can say, this percentage is the ones who, we have a box for, they just dropped, we couldn't find them anymore. And we have a box for, patient opted out. And so, we can start to put some correlations in there. But yeah, you're right, David. There's a lot of variables there. Stacey, you've had your hand up for a while.
Go ahead, Stacey.
Hi, thank you for this super helpful information. I'm curious if you have a metric on behavioral health care manager competence and engagement or satisfaction with the work.
Yes, I definitely think that I always measured behavioral health care manager satisfaction and PCP satisfaction and all members of the team. I think that can be really helpful information. There is one study that I can find that has some questions that I often give to organizations that are trying to build questions for their collaborative care team that has some examples in it. So I'll find that and email it to this group afterwards. But yeah, definitely really important information. And honestly, it's just not for everyone. I definitely had some pretty miserable behavioral health care managers that came from different backgrounds, and this wasn't the care they wanted to be providing or the approach they wanted to take. And that's okay. And, figuring out a way to support them and getting to where they would feel more comfortable and wanted to be. And so it's a different approach, and it, has to fit the person as well.
Thank
I'd be
you.
interested in seeing that, because what you saying that, Stacey, brought to my mind is their satisfaction being tied to maybe not be understanding the role of a behavioral health care manager or working in an integrated care setting, how that might directly impact their satisfaction in feeling like they're doing a great job or wanting to do the job or whatever it might be. So yeah, I think that's really interesting.
We have a survey we use with behavioral health care managers when we are supporting their implementation, where it's kind of competency, what they know at the beginning, and then more towards the end. And so we can really hone in on what, needs repeating or approached differently, or how to kind of use the last bit of time we have together. And that information has been really helpful. So yeah, doing some sort of survey of competency can help.
Are there set competencies for the BHCM as there are for traditional integrated providers? Yeah.
I don't know if they're set. Do you know if they're set, Monica? I don't think so. I mean, they need to be able to provide brief interventions. They need to be able to speak to patients about support medication management, and speak to patients about kind of med adherence, med tolerance, things like that. Yeah, be able to gather that information that's needed to bring to the psychiatric consultant. Would be the kind of 3 primary competencies.
There's like I mean, we all know that like integrated care, like for behavioral health clinician, has the really long competency list. For behavioral health care managers, there was a short, when Verna is saying that there was something that was developed by Ames Center at one point, but there's a short list of things that your behavioral health care manager is supposed to be able to do. I would equate that to be the competencies, and, you know, kind of develop things out based off of that, like things you might want to add in based on what you know your program, an individual working in your program might need, especially once you start thinking about what your target population is. There might be other competencies you want to add to or be more detailed about, but there are those few things that as a behavioral health care manager, you're supposed to be able to do.
Yeah, I don't think they're on the Ames website now, but I definitely remember them at some point. I'll see if I can find them. We did them for a project, but I thought they migrated over, but I'll look for them.
I can look for something, if there's something more that has just is similar but updated,
Yeah.
I put in the chat the link to the Ames Center Behavioral Health Care Manager role and job description, which has some good information about duties and responsibilities. And I would love to see that as well, because we basically, my team, we turned that document then into core competencies and things that we track on using that job description.
Mm-hmm. And and Tisha said there's the VA has competency measures for behavioral health care manager for initial assessment and follow-up. Yeah, I like that idea of using the job description
For onboarding, things of that nature.
Mm-hmm.
Well, thank you, Annie, so much for popping in today, kind of sort of last minute, but popping in today and talking about metrics with us. I'm going to turn it back over to the co-chairs.
Great. Thank you. I am so heartened to see over 20 people show up on the 3rd of January. So that is so exciting to see such an engaged group, everybody here and cameras on and talking and asking questions. I'm so excited about this year. Monica and Laura and I are going to be having a meeting in a couple of weeks, and we'll be meeting in between these meetings and kind of creating a game plan for the year. So just stay in touch on Basecamp and keep your eyes peeled on the listserv, the Gaggle chat, and we will have a plan for the year. And please, 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 please feel free to reach out to us and with ideas and questions and things that you want to see us working on. The conference will be coming up sooner than is imaginable, and we'd love to have some good collaboration in this group. I thought we had amazing, lots of really good talks last year, and really want to keep momentum that way. So just really excited. I'll let you take it away, Laura. Finish this up.
Yeah, I feel like for Annie, each of the slides that you had, we could have had an entire discussion just on that in an entire hour. So really excited about all the engaged conversation, and to echo what you shared, Tisha, I think it's going to be a great year.
Happy New Year, and we'll see everybody next month.